Good morning, everyone. Thanks very much for joining us this morning. I'd like to welcome you to the workshop on new data and data validation, which is, of course, going to be with focusing on COVID-19 research. My name is Refik Saskin. I'm a staff scientist at the Data Analytics Services Department at ICS. We will begin very shortly. People, I think, are still coming in. Before we do start, just a couple of housekeeping notes. We aim to make the workshop very informal and interactive, as interactive as, of course, Zoom permits. So please feel free to ask your questions as each speaker presents. You can do so either by using your own voice. Please remember to unmute your microphone, or if you prefer via the chat function of Zoom. We will be monitoring the chat, and I will be asking the question on your behalf at the earliest opportunity. Otherwise, please make sure your microphone is on mute. If you would rather save your questions for later, there will certainly be time at the end of the workshop to ask. Sorry, I was muted. My apologies. So if you'd rather save your questions, there will certainly be time at the end to do so. And also, please note that the session will be recorded so that we can share it later on. Without further ado, I'd like to turn it over to Hannah Chung, who will kick off the workshop. Go ahead, Hannah. Thanks.
Hannah, you're muted.
So good morning, everyone, and thank you for attending our workshop this morning. My name is Hannah Chung, and I am an Associate Research Methodologist here at ICS. And for the past 10 months, I have been primarily working on all the COVID-19 data, leading some of the data investigations and using these data for reporting and research purposes. Today, I'll be focusing on two main data sources, OLIS and CCM, Case and Contact Management, also known as OFIS. And the objectives of this talk are to introduce the COVID-19 data sets and describe the process of making them research ready, two, to share challenges, data quality issues, and limitations of their usage, and three, to summarize the data sets for timely COVID-19 reporting. And before I get into the presentation, I'll be stopping my video just to ensure I have some bandwidth throughout this presentation. Okay. So I'll start off with OLIS. So since April 2020, ICS received daily extracts of COVID-19 test results from the Ontario Health Digital Services. And actually, ICS has been receiving OLIS quarterly for other laboratory results such as PSA, lipids, microbiology for a couple of years now. But this data cut was specific to COVID and was created by extracting COVID-specific test requests and LOIN codes, which are listed here. Also COVID SNOMED codes, and using keywords and strings found in the text of test descriptions and results. So using the in-house expertise of our health information analyst, Branson Chen, and other research staff, a Python code was developed to parse out lab results pertaining to COVID-19. We were able to develop and validate this code quickly by adapting an existing code that cleaned results for respiratory viruses. And we worked very closely with teams from the Ministry of Health, ODHS, and subject matter experts. So the goal of this code was to derive an efficient way to interpret large amounts of COVID-19 data so that it could be used for timely reporting to inform decision-making and for research purposes. So to note, within 10 days of receiving the first data feed, we provided our first report to the command table on testing in long-term care and retirement homes. So the Python code is published under an open source license and is currently used by the Ministry of Health and other organizations. And I encourage interested people to visit our GitHub page for more details about the codes and the decision-making steps that were made. But to summarize, the code takes the raw text results from OLIS, parses out elements into clean strings and tokenizes it, and then assigns the results. And all this work happened last April, and the code has been enhanced over time. And right now, we are working with teams at the MOH and Ontario Health to develop a code to parse out mutations and variants of concern. So after cleaning the raw data, we created an analytically friendly data set where each row represents the results of a tested individual on a single day, which we called a testing episode. So this diagram just outlines the steps of how raw results are aggregated and rolled up into a testing episode. And to validate our data, we compared our counts and tests to cases that are reported publicly. However, as this graph shows, and which was created by one of our data quality analysts, we noted that our counts that were derived from OLIS were lower than what was reported on the government's website. And just to orient people to this graph, this just restricts cases from September 2020 to current, but the pattern was seen consistently throughout the pandemic, where the blue line represents the cases reported on the government's website, which is based off of IFIS CCM, and the pink line identifies the cases that are identified in OLIS. So we have a degree of underreporting if we use OLIS alone. Other indications of underreportings are that we saw our first positive case in late February of 2020, and we know that the first one in Ontario was a month earlier. And another indication is that from our experience with the regular OLIS feeds that we receive, we are aware that some labs in Ontario do not contribute their data to OLIS. And we saw this with some labs for their COVID-19 results. For example, Hospital for Sick Children, we are aware that they were performing tests like earlier on the pandemic, but we only saw their first test in OLIS in April 2020. However, it is my current understanding that most labs are submitting their COVID-19 results into OLIS now. So another major data limitation with OLIS is that it lacks clinical information that we also do not have in our other ICS administrative data sources. And this includes setting a specimen collection, whether it's a long-term care, an assessment center, the reason for testing, whether it's for they were tested because they were close contact, because of a workplace outbreak, or because of travel history, outbreak and investigation numbers, which are specific to the outbreak and contains information about, where and who was tested, like staff or residents. We don't have information on symptom status and also healthcare worker status. But however, just to mention, this information is collected on the laboratory paper requisitions and entered into the local laboratory information system. But the information is not submitted into OLIS for all labs because this depends on the infrastructure and configuration between their systems and OLIS. So I'll just pause here if there's any questions regarding OLIS, or if not, I'll just move on to IFIS CCM.
Thanks, Anna. There are no questions in the chat.
Thank you, Refik. Okay, so the next data source that I'll be discussing about is the Public Health Case and Contact Management Solution, CCM, also known as IFIS. So since May 2020, ICS received daily feeds of the COVID-19 module of the Integrated Public Health Information System, IFIS, and CCM has replaced IFIS for all public health units. These systems are used to collect information on COVID-19 cases throughout their case and contact management process. And ICS actually receives a very clean and readily usable version of this dataset, which is created by a dedicated team from Public Health Ontario. CCM contains information on confirmed cases only, and for example, risk factor information such as occupation and congregate settings, whether it's a shelter, a long-term care home, or a retirement home. And this information is not, we cannot get from our other ICS administrative databases, so it does add a lot of value. CCM also contains info on clinical information, interventions to treat COVID and outcomes such as hospitalizations and deaths. And, for these outcomes, like we technically can find them in our ICS databases, but our data is lagged. And so CCM could be used for more timely reporting because it updates this information almost every day. So because CCM is a new data source at ICES, we wanted to compare some of the elements with our administrative data before we decided which data source to use for our reports and research projects. So we undertook, a small little investigation where we selected a couple of variables from IFIS, such as comorbidities and outcomes. And then we also created analogous concepts using our administrative data. So for example, we compared the self-reported chronic conditions with the ICS validated and widely used algorithms that most research project teams use to identify individuals with these conditions. And these are based on algorithms on healthcare utilization and diagnostic codes. Another example is hospitalizations, where we looked for a record in our discharge abstract database with a COVID-19 diagnostic code. And for this investigation analysis, we restricted to cases reported between January and June 2020. Since this is a period of time where our administrative data was relatively complete. So the next, I'm just gonna show, and so we did this comparison using the administrative data definition as the gold standard and determined if the individual had the analogous IFIS CCM variable recorded. And we did performance metrics such as sensitivity, specificity, positive predictive value, and negative predictive value, and also a kappa statistic. So the next two slides are not published results, so I'll quickly go over them. So CCM does have many advantages such that it identifies all the COVID cases and that we see are underreported using OLIS only. And also it contains information that is not readily available in our administrative data. But we did experience a few challenges because this is, again, it is a new data set at ICS. One of the challenges is linkage to administrative databases. So for those in the audience that are not aware, ICS has the ability to link across multiple databases using an encrypted identifier called the IKN. And if data comes in with the Ontario health card number, we can easily assign its IKN. However, records without health card numbers, we have to use other methods. So the linkage is really dependent on the quality and completeness of identifiers. With IFIS CCM, around 85 to 90% of cases are linked by their health card number, which is pretty high. But for the ones that are not linked by their health card number, we had to use other approaches like matching by their full name recorded in IFIS CCM with the registered persons database. And the next step would be to link them with more sophisticated methods like deterministic and probabilistic linkage. But however, in any given data set, still around 6 to 8% of cases are not linked. And as of yesterday, this is around 19,000 cases that we are unable to link and use for further research purposes. Another challenge we experienced is this IFIS CCM is a very dynamic database. We receive a cumulative data set daily. And again, information is updated by the public health units every day. New cases can be added, new information can be added, updated, corrected. And also over time, as we learn more about the pandemic, a lot of new variables were added into IFIS CCM. So, the level of completeness does vary. And again, this is something that compared to our other data sets where we don't get a daily feed, this is something new for us of how to assess quality and what can we use and not use. So these are the two challenges we experienced with CCM, and still it's a learning process. And once it is more widely used, we're definitely planning to share it on our intranet page for internal research teams. So just to kind of close off this presentation and to talk about what we've actually used with OLIS and IFIS CCM. So as I mentioned, OLIS and IFIS CCM can be linked to each other and to other health administrative databases using that ICS unique encoded identifier. And as mentioned before, OLIS is underreporting, and we capture around 85% of cases. And by supplementing with IFIS CCM cases, we can actually now identify 95% of reported cases. And the reason why it's not 100 is because of that large proportion of individuals that could not be linked because they didn't have health card number or any other identifying information for linkage purposes. So this Venn diagram is not proportional, but it does kind of depict reasons for why an individual will can only be identified in OLIS, and why individuals can only be identified in IFIS CCM, and the overlap in both. So again, a large issue could be about, we can't see their test in OLIS, but they're also in IFIS. Or we could see their test in OLIS, but they were not linked in IFIS. So there are multiple reasons. And again, this was a learning process of how to deduplicate and identify individuals in both data sets. So again, as mentioned, we are able to kind of link across multiple data sets that are housed at ICS and can report on, individuals tested for COVID or individuals positive for COVID, and kind of characterize them. For example, we do a lot of reporting by the public health units and identifying them by identifying their public health units using these two data sets. Again, using a series of data sets to identify whether they're a long-term care home resident, chronic conditions, and healthcare utilization. We could also link them at the individual level to the Immigrant, Refugee, and Citizenship Canada IRCC database, where we could get immigration status, recency, category of immigration, like if they're a refugee or a sponsored family, and also their country of birth. And we could also link back to IFIS CCM to get those risk factor information that is not collected in our administrative data bases, such as healthcare worker status and long-term care worker status. So this slide just shows one of the, reports that we released. This was a report that was released last year and led by our Chief Science Officer, Dr. Astrid Gutman. And it basically uses pretty much all of our data sources that I depicted in the slides previously. So we identified cases using OLIS, linked them to the Immigrant, Refugee, and Citizenship Canada database, IRCC, to determine their immigration category. And then we also link them back to IFIS CCM to get their healthcare worker and long-term care worker status. And basically what this shows is that immigrants, there's a higher proportion of healthcare workers among COVID cases in immigrants compared to Canadian-born and long-term long-term residents. And lastly, again, using these data, we have done facility level reports for long-term care and retirement home testing. We provide weekly reports on testing and percent positivity at the PHU level to all PHUs, and also at the forward sortation area, which is the first 3 characters of someone's postal code. For some public health units, we also provide more at the neighborhood level. So if you ever seen the Toronto Public Health COVID-19 dashboard, some of the information was provided by the data that I presented here. And more recently, we have been asked by the public health units to kind of use our data sources, all the administrative data sources in terms of identifying comorbidities and age groups to create some population estimates on clinical priority groups. And this is being used for vaccination planning at the public health unit level. And lastly, which Lesley will go into at her presentation, we use these data for our COVID-19 dashboard as well. So that is the end of my presentation. I see that there are some questions, but Refik, if you want to help me facilitate them.
Sure, of course.
I'll start
So there's a, yeah, thanks, Hannah. Very informative. There are 3 questions currently. Maybe we can all kind of answer them. So the first one is, do the PHUs enter data to CCM in real time or batched? For example, when outbreaks are closed. Do we know the answer to that?
I don't know the answer, because definitely something that we can't monitor on our end, but again, we do see changes with every daily data feed. So my understanding that they should be entering in real time, but there's 34 PHUs, and I expect there to be some variability, and it also depends on the caseload as well, right? So it should be in real time, yes.
Great. The next one is, who is currently able to use the CCM data at ICS?
Right now at ICS, it is not widely used. It's going through the final stages of, I guess, data sharing agreements, but it should be available to project teams in the near future, yes.
Great. And how frequently do we perform linkages of the CCM at ICS?
So the linkage with the health card number is, again, based on the daily feed, which we process twice weekly, because again, we only do our reports 2 times a week. But the probabilistic, so the exact matching, which is by first name, last name to the registered person's database, and deterministic and probabilistic linkage is led by Winnie Shen of the information management team. And this is done every 2 to 3 weeks. Again, like, because it's a daily feed, there might be records that didn't have the health card information, but the next day they did come with it. So we compile a couple of records over, 2-week period, and I'll link it once every 2 weeks or so.
Great. And I expect I know the answer to this, but I'll ask it anyways. Are the results of whole genome sequencing captured at OLIS?
So not currently in OLIS. It just started trickling in. So again, Branson Chen, who is our expert in Python coding, and other members of ICS and the MOH, we are actually trying to figure this out in OLIS by looking through a lot of free text. I don't know about whole genome sequencing, but we'll actually know the mutation and the lineage. But again, it's what's reported by the lab. So I don't think they put like detailed DNA sequencing information into OLIS. But
I don't think so.
Have an update
I can weigh in on that. We've been working with Genome Ontario, and actually the organization that are sequencing the whole process of sequencing is happening there. There is a challenge in terms of the linkability of their data with OLIS. So we are still trying to figure out how they can submit the information to OLIS, or they can have a common identifier between their data and OLIS. So the genome sequence is there, OLIS is there, they're not linkable, unfortunately. So it's a challenge, an ongoing challenge.
Yeah, I mean, from the looks that we had in the past few weeks, we're able to identify if they're screened and if they're positive for a screen and if they went to sequencing, but it's just the lineage result at the end. So if it's a B117 or such. So again, we're trying to make that into an analytically friendly data set for use right now.
Great, and I think there's one more question. Will we be able to access these data through data analytics services as third-party researchers? So it really depends on the data sharing agreement for CCM. OLIS and all of the other data sets that Hannah kind of indirectly mentioned are already available for third-party researchers. But I do await the data sharing agreement results for CCM.
Yeah.
Any other questions? I don't see anyone else in the chat. Anyone else, quote unquote, in person? No. All right. Thanks again, Hannah. This is it's super informative. I will turn it over to Mahmoud now.
Thank you, Refik and Hannah. So just bear with me to share my screen. Am I good? All right.
Yep.
Good morning, everyone. Thanks for joining our session and not going to other sessions. Thank you, Hannah, for the very informative information. You heard from Hannah about IFAS and OLIS as major source of information about COVID test results. So I'm going to talk about a little bit of advanced methods and tools that we are using to enrich this data and actually get more information out of it to fill some gaps. But before doing so, I would like to a little bit touch about the administrative data that we have that are being used and supporting the research for COVID, and how we were able to use them in a more frequent and more timely manner. So as you heard, COVID-19 test data are coming to ICS from the first few months of pandemic on a daily basis from OLIS and IFAS or CCM. From the very first few months, we worked with COI to get more frequent feed of data knackers. The data are incomplete, but still a good source of information. Depends on what type of information you are expecting to use. So for some type of research, they are still very useful. And I'll get to a little bit of more data quality and completeness of these two data on a more frequent fashion that you're receiving. We also started preparing and posting physician claim data, or how we call it at ICS, OHIP, and also RPDB, registered person database, on a monthly basis to have more synchronized data as a whole picture. RPDB, as Hannah also touched on, it has the lag issue. So it lags more than 6 months, especially in mortality. And I'll also expand on that a little bit further later. There are data that we create at ICS, such as ICS drive cohorts. A very good example is mom-baby cohorts, which has linked maternal delivery and infant birth hospitalization. So since that knackers, RPDB, and OHIP now becoming, and a few others like ODB, Ontario Drug Benefits, becoming more frequently available during the pandemic at ICS. So those who maintain and create these ICS drive cohorts, such as mom-baby, also took the effort to run their algorithm on a more frequent, basically, fashion. This graph gives you a sense of the availability of different data holding and how they align in terms of the availability and completeness. As you see, some data are catching up more over time, but there are significant lags in some others. And that's the reality. And we are trying to provide as much as information to our researchers and analysts to be aware of the limitations and what is available and what is missing from our data. These two graphs also shows how timely are data knackers. So as I mentioned, we are receiving data knackers on weekly basis since pandemic started. But that doesn't mean that the weekly feed completes or is complete, or it actually covers all the institutions and hospitals across Ontario. There are institutions and hospitals that have the infrastructure and resources to submit their data on a weekly basis, or some in after a few weeks. But there is no mandate on Ontario hospitals to do so. So basically, COI is sharing whatever they receive with us. So just to keep our data with COI on a same level in terms of the information. Here you can see on the top for that in order to cover majority of the records or majority of the institutions information in that at ICS, it takes at least 12 weeks after the discharge date for data to land at ICS. Although, if no matter if you're receiving it weekly or not, still we have to wait at least 12 weeks to kind of the data becomes reliable. Lower for the NACRs and ED, you can see it's a little bit shorter, the waiting time. So in about 8 weeks, you can get a good proportion of the data arriving at ICS, but still it takes up to 20 weeks to basically be sure that you have received everything that you need. Hannah mentioned mortality data and the comparison with IFAS CCM information about death. I'm trying to illustrate the lag of the mortality data for you using RPDB, Registered Person Database. So let's start with 2016. So this is, as you see, this is the pattern. You know, in the colder months of the year, you expect to see more deaths in Ontario, and then over the summer, it goes down and then again goes up in the winter. 2017, you see pretty much the same pattern, a little bit increase. The population is increasing, the mortality rate is increasing, so that's the normal growth in the data. 2018, again, pretty much the same pattern with some increase in the mortality. And 2019, so it keeps the same pattern, but you see it's lower than 2018. That can't be correct. So that shows sort of the lags that we are expecting. But when we go to 2020, you can see it a lot better. So this information comes from August 2020. So the data that we received in August for up to April, it shows increase comparing to the previous year, but all of a sudden for May, June, and the rest of the months, it goes down. We ran the same analysis later in November, and as you see, it was able to catch up a little bit, but still not enough for the following months. So basically, in order to get reliable information, death information from RPDB about April, you have to wait at least until November, which is 6 to 7 months. But still, you know, if we run the same analysis next year, you will see changes here. So these changes are constantly happening, and there are lags from different reasons. The information that is submitted to the Ministry of Health to RPDB. So these are all showing the limitation of the data. Even though we are trying our best to provide more frequent data, still there are limitations. But there are limitations on other side of the data, that there are no data, absolutely no data available. And the best example is retirement home. As we all know, one of the COVID crisis in Ontario and all around the country was in retirement home. And from the first few months of the pandemic, we were tasked to identify the tests that were happening and positive cases in retirement home. But there is absolutely no data, individual level data, that we could use it in order to link it with OLIS COVID or IFAS data in order to identify who is from retirement home. But we try to basically get a little bit, to innovate and find a way to enrich whatever we have. We noticed in OLIS, patient level data comes with address of the patient, the resident of the patient. So we thought if we collect all the retirement home addresses in Ontario and run a linkage on addresses between the two data, we could be able to flag individuals who've been tested in retirement home. If we wanted to do it in our traditional way, using probabilistic record linkage, it would take us weeks, if not months, in order to complete the linkage for the volume of the data that we are dealing now, especially on COVID test results. So we decided to use a different methods and different tools that we had it at ICS, but we were just exploring it. So we weren't very, very experienced in that methodology and tools, but we thought this is a good time to take the risk and try to develop something there. Other examples, as you see, the gap of the data are timely long-term care homes and homeless shelters, individuals in homeless shelters or correctional facilities. So these were all areas that we wanted to know in terms of the COVID, what's happening there. So what we did, we used tools by SAS. It's called, used to be called SAS Data Flux. Now it's more known as SAS Data Quality. It does fuzzy matching. It actually leverages fuzzy matching algorithms and techniques for entity resolutions. And it comes with built-in quality knowledge base, or QKB, for different languages and countries to enable data standardization. So for example, there is an additional tools or QKB or plugin that comes with it that is developed by Canada Post for validation or correction of the addresses in Canada. So we equipped the tools with all of these additional plugins in order to standardize the two addresses. One address is the list of addresses from retirement home that we received from RHRA, the regulatory body for retirement homes in Ontario, and the addresses that are available in COVID data. And when I say we, all the credits goes to our data science specialist, Ganga, who is in the audiences. And if there are questions, she would be able to answer a more detailed question. So basically the process is to clean the address field on both data set. Then we run it through Dataflux to standardize the address fields on both data sources. And then we generate some sort of encoded representation. And that is in this, in this tool, it's called the match keys. And then the match keys being linked together in order to identify those who live in retirement home or any other congregate settings that we use. We are hoping to use these methodology and tools for further enriching data. But let me start with current limitations of these methods. The process is very resource intensive, so it wasn't that difficult at the beginning of the pandemic, but now we are dealing with millions of records in OLS COVID, for example, those who've been tested, and the volume of the data is growing. That requires a lot of resources, like computing powers. To address that, we started creating a new environment, a dedicated environment, dedicated CPU, RAM, storage, everything, in order to allow more efficient run of these fuzzy matching data. And the other limitations here was, although we were able to create retirement home flags in OLS COVID data, the challenge still was we still don't know the denominators for the entire population who live in retirement homes by the same demographic or other conditions that we want to study for those who are positive or negatives. So what we are planning to do in the next few months is to run population level matching to identify individuals living in retirement homes or affordable housing or even correctional facilities. And by that, I mean the RPDB. Instead of running the fuzzy matching on COVID data, we will be running the fuzzy matching on the entire RPDB that has the over 20 million records, and it's being updated every month by the Ministry of Health, and receive a copy of that. So we have all the addresses for every individuals who have been issued a health card number, OHIP cards in Ontario, and all the changes in their addresses. When they move, as you know, you are supposed to report it to the Ministry of Health. So we are hoping to run this same methodology on the entire RPDB to flag individuals in the population who live in these type of congregate settings. In addition to that, we are hoping to use a similar methodology, but instead of linking basically two data sets, we are hoping to classify or group, if you will, multiple different addresses or different individuals using their addresses to identify those who live under the same roof and flag them as household identifiers. So that's another big gap and lack of data in Ontario. So we don't have any information that provides us with the family relationship. Or, you know, in this COVID era, what we call it bubble. So in order to understand who are in the same bubble, if we could actually run this methodology for the entire RPDB, we will be able to some sort of coming with some sort of proxy to identify those who live in the same household. We already know that it would be a lot of challenges in order to achieve this. For example, in RPDB, not necessarily all the addresses are residential addresses. A lot of them are mailing address. So we know that we have to deal with those, and moving individuals from different addresses that are not necessarily up to date in RPDB would be another challenge. But this is again in the horizon in the next few months to give it a try at ICS. And finally, sneak peek at vaccination data. So full disclaimer, this is not ICS data. We don't have vaccination data yet. So this is public data from the Government of Ontario Open Data Catalog daily administrated doses in Ontario. However, we are working hard in order to receive vaccination data, and we are in the final stage of data sharing agreement with the Ministry of Health. So the individual level, patient level vaccination data will be coming hopefully soon to ICS for linkage and data processing. And based on the information that we have received so far, we should expect to receive information on vaccine inventories, vaccine shipments, and of course, administrated doses, which are the individual level information, patient information with all the identifiers in order to link it with other data. And also if they have any COVID symptoms and other conditions like allergy to vaccine, or if they have received other vaccine and they had reactions. So these are the information that seems like that are being collected in the vaccination database, and we've been provided that you should receive these, and hopefully in the next little while, which I don't have the timeline yet, we should be able to receive the vaccination data and link it and making it available for our projects. So that was all. I would like to acknowledge a few colleagues who provided me with some of these information that I used here, and some of the work's been done actually by these individuals. And you have my contacts if you have any follow-up questions, but I'll be happy to answer any question here.
Thanks, Mahmoud. There is one question related to vaccination data, and that is vaccination information within OLIS?
No, there is no vaccination information within OLIS, and I don't think there is any plan to incorporate that, as far as I know. But the hope is that when we receive the vaccination data, we will be linking it with OLIS, of course.
Thanks, Mahmoud.
Thank you. So
yeah, there's one more.
Sure.
Is the vaccination information from COVAX, C-O-V-A-X?
That is what the data is called. So the information that we received is COVAX. So that is apparently, I guess it's called Ontario COVAX, ON COVAX, if I'm not mistaken.
Great. Thanks, Mahmoud. Anyone else? through chat or in person? Doesn't sound like it. But you know, again, there will be time at the end to ask other questions. So thanks again, Mahmoud. I'm going to turn it over to you, Lesley.
Hi, everyone. Can everyone see my screen, hopefully? My slides? Great. Okay, so thanks, Mahmoud and Hannah, for starting us off. And we're going to be the final presentation here, just to sum up some of the applications of this COVID data across the various project pathways that we have at ICES that are available both for have generated both public and project-specific data consumption. And then it's also available both for internal and external stakeholders at ICES. So as you can imagine with you know, the information that we've just shared with you, the COVID data at ICES is in high demand. To date, there's over 120 projects at ICES that are utilizing the COVID data in some form. These projects cover all departments and portfolios at ICES, and they're available for both internal and external stakeholders, as I mentioned. So we have projects through the Applied Health Research Question, or ARC portfolio, with Indigenous partners through our Indigenous Health portfolio, for third-party research, which is through the Data and Analytics Services branch of ICES. There's also internal projects through RNA that are led by ICES scientists. And then we also have the ICES COVID-19 dashboard, which is a component of a larger ARC with Public Health Ontario. And that's generated a lot of publicly available data, graphs, maps, infographics through the course of the pandemic. So we'll cover some of these examples as we move forward. So first I'll highlight a few of the requests that have come through the ARC portfolio. So for those of you who are unfamiliar with ARCs, these are projects that are funded by the Ontario Ministry of Health, and they're from eligible knowledge users. And this is used to generally answer a research question that will help inform the entire Ontario healthcare system. So they're around informing public policy, planning, also management. And we use this pathway to provide information back to external stakeholders that can go and act on the information based on their research question. So ICES is one of several research providers that provides this service in Ontario. And we think we're well positioned to provide this information because of the data holdings that we have in-house, as well as now we have the cleaned COVID data that's available for use. So in spring of 2020, as many projects were getting underway related to COVID, and we were rapidly receiving and cleaning the COVID data, a COVID committee was established to adjudicate incoming ARC requests. And one of these projects came from the Ontario Ministry of Children, Community and Social Service, or MCCSS. So the request was to provide immediate and ongoing COVID testing and positivity rates in vulnerable populations, which largely fall under the jurisdiction of MCCSS. And to respond to this as soon as possible, the approach was to rapidly turn around populations that ICES could identify easily with our current data holdings. So for example, we could easily identify seniors, low income using the neighborhood income quintile variable, marginalized population using the Ontario Marginalization Index, and then also to identify populations that we had validated algorithms that had already been developed. So this is for populations like individuals with developmental disabilities and children with medical complex or chronic conditions. So we've been reporting to MCCSS since June 2020, accumulated COVID testing and positivity results in the populations that are listed here. And this information is made only available to the ministry. However, they've been using the information to report into the vulnerable population subtable, which then subsequently reports into the larger command table in Ontario. So as these reports evolve, there's been particular focus on the impact of COVID on individuals with developmental disabilities. And this has spurred several additional projects, including a subsequent ARC that's requested to dive deeper into the severity of COVID-related outcomes in individuals with developmental disabilities, and also on the general access to care during the early months of the pandemic. So as mentioned earlier in the presentation, there is a lag with some of our data sets, but we're now at the stage where we can start to report on outcomes. So for example, the severity of COVID in COVID positive cases. We can look at hospitalizations, ED visits, mortality, although as Mahmoud alluded to, there is a lag in that data. And we continue to tailor our outputs to best inform the ministry based on each phase of the pandemic that we're approaching. So this is just an example of project-specific reporting on COVID, but I'll also talk about some of the public-facing reporting that we've done using COVID data. So as part of another ARC request that we had with Public Health Ontario, the ICES COVID-19 dashboard was initiated in May 2020. And this was designed to be a digestible, user-friendly webpage that's tailored to the public, and then also other jurisdictions that may be looking for additional resources. So if you were to go to our website today, this is the page you would see. It's under the Data and Analytics Services tab, and then there is underneath an ARC tab, so you can find it there. And it includes both static and interactive COVID-19 related metrics for all of Ontario and also smaller geographical units. And it's updated weekly and is found on the ICES website, as I mentioned. So the first iteration of the dashboard included reporting on COVID-19 test recipient characteristics at both the provincial and the public health unit level. And it had a series of infographics and maps. And over the course of the pandemic, we've evolved the dashboard and expanded to better address each phase. So just to give you a taste of how frequently the dashboard and its contents are accessed. So beginning from May of last year, so May 2020, to just a few days ago, there have been over 98,000 page views of the dashboard. The COVID interactive graph, which tracks percent positivity by age group and PHU, has been viewed over 8,500 times. And the first public report that was published on the dashboard, which is titled COVID-19 Laboratory Testing in Ontario, Patterns of Testing and Characteristics of Individuals Tested as of April 30th, 2020, has been downloaded over 2,000 times. So the dashboard's gone through many iterations, as I mentioned, over the course of the pandemic. And one series of graphs that generated a lot of traffic were these bubble graphs that were generated actually by Hannah and other ICES colleagues. And these were first published in late 2020 as there was a big push to report testing and positivity on smaller geographical locations. So these bubble graphs were designed to show the variability in testing rates and positivity amongst FSAs, so forward sorting areas, the first 3 digits of the postal code, within a PHU. And ICES was producing these graphs for PHUs that had a percent positivity greater than 2.5%. However, over the holidays, many of the PHUs were surpassing this threshold, so it became difficult to produce all the graphs for all the PHUs. So they've been put temporarily on hold. But not to worry, they are coming back in a new form, which I'll talk about in a few more slides. So the dashboard itself provides both routine and also featured reports that we put on the website. As I mentioned, it's updated weekly. So each week you may find a new type of report or something that you've seen consistently throughout the pandemic. So this is just another screenshot. If you were to go there today, you would find this graph, and it's percent positivity by FSA for the most recent reporting week up to February 6th. And this has become a regular reporting feature on the dashboard, which we also provide as a downloadable form. So there's an Excel file that's listed underneath this table, which will provide you with all the FSAs in Ontario and their percent positivity. And then within this past week, one of the latest features has been looking at the proportion of FSAs within each public health unit by school transmission risk category. So this is to coincide with the reopening of schools across Ontario. So for example, if you were to look at the bottom row of the Toronto Public Health Unit, which is where I'm located, where I'm broadcasting from, you'll see that of the 101 FSAs that are in Toronto PHU, nearly 90% of them are in the higher and highest risk categories for school transmission, with the majority being in the higher risk category. So we provide this in table summary form on the website, but again, we also provide this information at the individual FSA unit in a downloadable Excel form, which is found just underneath on the dashboard itself. And then now just a sneak peek, something that's upcoming in the next few weeks, which we're happy to share today with you, is that the dashboard is getting a new interface. We're going to be using Tableau to allow for more interactive and flexible reporting for users. So this is just a screenshot. We weren't able to go through a live demo today, but we just wanted to give everyone a heads up to check back in the upcoming weeks. As you can see from the screenshot, there's a lot more kind of user options. So you can modify by the time period and also the geographical location, just to be to provide the user with more flexible reporting. And then finally, I'll talk about another avenue or project pathway that we have at ICES, which has also been able to utilize the COVID data. And this is through our Indigenous partner, portfolio at ICES. So we've been working with the Indigenous communities for many years, and we've developed a unique data governance and data sharing agreements to conduct this conduct this analysis using our ICES data holdings. And there are a number of ongoing projects that are currently related to COVID data, and they're reporting back to Indigenous communities across the province. So in particular, one partnership that we have is with the Métis Nation of Ontario. So for some background, in 2016, a data governance and data sharing agreement was struck between ICES and MNO, which enabled the linkage of the MNO Citizenship Registry, which is a data set that contains about 20,000 individuals. And also it linked in the MNO household survey. So within this agreement, a committee was put together to adjudicate the requests, as well as try and create a collaborative partnership so that research was being done as more of a collaboration using the ICES data that was available to the community. So with this established partnership in place, ICES was well positioned to provide timely COVID data to the community. And we provide weekly testing and positivity reports for the citizens of MNO. And this information is being shared throughout the community. And President Margaret Fro recently presented this data to the community in an MNO town hall back in January. So just to wrap up, I've highlighted a few examples, but there are many examples that are found across the various departments within ICES. I myself am focused on the ARC portfolio, and Refik is focused more within the third-party research portfolio. But we're happy to answer any questions on ways to access this data and potentially how to initiate projects through these avenues, especially for external stakeholders. But I'm happy to take questions, and if you'd like to, you feel free to reach out to either of us. So thank you.
Thanks, Lesley. Before we go there, I think there's at least one question in the chat moment, but before we go to the questions, just a bit of advertising for data analytics services, if you will, shameless plug on my part. But for those of you who are perhaps not aware, we are able to share most of these data sets, I think with the exception currently of the CCM data, pending data sharing agreement, with third-party researchers through our secure platform, whereby you would have access to highly de-identified individual level records, which are essentially extracts of all of our data sets. So if you have your own research ideas and you would like to have access to our data and do analysis yourselves, please feel free to reach out to either Lesley or myself, but yeah, probably mostly me, and I would be able to give you more details as to how you can make that happen. But yeah, thanks everyone for joining, and thanks to Mahmoud, Hannah, and Lesley for lovely informative session. There is one question. I think it's probably mostly going to go to Hannah. It's about the dashboard and reporting of percent positivity rate. Someone was asking if it's possible to see the raw numbers of tests, both positive and negative by age. You're on mute, Hannah.
First, thank you for that question. Unfortunately, the reason why we don't provide the raw numbers is because we want to reduce the risk of re-identification. ICS cannot provide small with less than 6 counts. But what we have done is provided the incidence rates using a population denominator. But again, it is output to output specific. A lot of our publicly available information is by smaller levels of geography and age groups, so that prevents us from providing those raw counts.
Thanks, Hannah. Anyone else? Looking at the chat, nothing seems to be popping up. Anyone quote unquote brave enough to ask the question in person? Nope, doesn't sound like it. Any last comments from Mahmoud, Hannah, or Lesley?
No, thank you. Nothing from me. But again,
thank you for attending.
I would like to encourage everybody to speak up. This is supposed to be very informal session, so feel free to speak up if questions.
Yeah, and if not, you have our contact information, and please feel free to reach out directly with any specific questions. And thank you all for attending. It looks like it was a fairly strong attendance, 80 so individuals, us discounted, so that's great. Yeah, someone's asking where can we get copies of the presentation from today. I'm not sure. I'm sure they're going to be made available on a website. At some point, the sessions are recorded, so I presume you will be able to view them at a later time. And also, the winter forum continues at 11, so please continue attending these sessions. Okay. Thanks, everyone. I guess we'll just. Someone is saying the workshops will be posted to the Hua app by Friday. Thanks, Reba, for that information. I appreciate it. Thanks, everyone. Enjoy the rest of the forum.
Thank you.
Bye. Thank you.
Thank you. Bye, everyone.